Thank you so much for letting me present our interesting cases of bone marrow failure in two siblings. The first patient we saw was a 53-year-old male, initially referred to our clinic just to kind of do a rule out of bone marrow failure. So he was initially seen by an outside institution and diagnosed with leukopenia after he had some labs done for kind of recurrent cold and allergy symptoms. You can see his white count was a little bit decreased at 2.3. But then within 3 years, he progressed to full pancytopenia with hemoglobins dropping as low as 6, and then naters of platelets of 49,000, and then ANCs of around 600. So he remained transfusion dependent for several months, and then had a bone marrow evaluation, which did show trilineage hematopoiesis, but did show some hypocellularity. No dysplastic features, but did note some reticular fibrosis and then increased lymphocytes within the marrow as well. A repeat marrow 6 months later additionally showed hypocellularity and then continued marked fibrosis as well. Had some genetic workup for some of the common causes of fibrosis, JAK2 mutations. He had some PNH testing. That was all negative, and then ANA was positive. So he was ultimately diagnosed at an outside institution with aplastic anemia, kind of idiopathic, was started on immunosuppression therapy with ATGAM and cyclosporin, continued on the cyclosporin, which actually normalized his blood counts, and then he was trialed off the cyclosporin, and then that's when his counts started to drop again as well. So he was considered at the outside institution for transplant, then actually referred to our institute kind of for a more thorough workup of bone marrow failure. So you can see when we initially saw him, we did a little bit additional lab work on him. And this is actually before his cyclosporin was decreased. And so his counts actually looked pretty good, some lymphopenia, but his counts looked decent on the cyclosporin. You can see he had on T and B cell subsets, had low T sets. And then you can see he had some hypogam as well too. His brother actually had an interesting clinical history as well too, and was seen by our clinic. So he was doing well until about age 52, when he had a bout of cellulitis, and his CBC at that time was noted to have leukopenia and significant neutropenia as well. And you can see that his neutropenia actually persisted on further repeat testing, kind of in the low 100 ranges. And then he had an interesting infectious disease history, had actually a Fifth disease as an adult, and then shingles, and then erymonis hydrophilia, infection of the leg 5 times. So he ended up actually having a bone marrow biopsy as well, which did show some, a little bit of hypocellularity, not too bad for a guy his age, but did show some fibrosis and then some small lymphoid aggregates as well too. So his evaluation was notable for low IgM, and then obviously that significant neutropenia as well too. His T and B cell subsets did look okay though. So kind of given the fact that we had these two siblings that kind of had an unknown diagnosis and kind of this hypogam picture, we actually ended up going straight towards whole exome sequencing, which revealed the novel mutations in the CECR1. And then the father had been deceased, but the mother was still alive, so we did testing as well for her, and she was heterozygous for the mutation. And then with the help of Dr. Hirschfield's lab, we found that both patients actually had low ADA2 activity as well. Cytokine 12 panels did show elevations in TNF-alpha in our first patient, the one with more pancytopenic features, and then kind of borderline high levels in our patient 2, the one with predominant neutropenia. So we actually tried our first patient on Humira, and he actually had a good response in that, where his counts had recovered. They had downtrended after going off of cyclosporin, and then once starting on Humira had actually normalized again. He did develop some polyarthritis, though, that was concerning for serum sickness, so he was actually transitioned to etanercept. And he's actually followed at the NIH now, along with his brother, and his brother is also on etanercept as well too. And our initial patient, patient 1, actually his counts have maintained stable on the anti-TNF therapy. His brother, kind of digging through his records, looks like he still is having the neutropenia. It doesn't look like it's resolved on the etanercept. And so just kind of reviewing our the pancytopenic patient's labs, you can see kind of before he started on the ATGAM and cyclosporin, he had pancytopenia. Had a little bit of increase in his white count and hemoglobin, and then actually looked pretty good. He was taken off the cyclosporin, trialed it off, and then you can see his ANC dropped again, his hemoglobin dropped as well. And then after starting the Humira, his counts actually came back up. His hemoglobin was an impressive 16.6. So kind of I know we had a lot of discussion about, is this kind of an intrinsic effect on the kind of hematopoietic stem cells? Is this more of an intrinsic effect on the bone marrow kind of inflammation? So no clear answer. If you look at, TNF-alpha in other cases of bone marrow failure and aplastic anemia, you do see that TNF-alpha has been found to affect hematopoiesis by kind of leading hematopoietic stem cells towards the apoptosis pathway. And then patients with idiopathic aplastic anemia have been found to have some dysregulation in TNF-alpha as well too. And then so we have really thought that in these patients, trialing anti-TNF-alpha therapy could be useful and potentially have some patients not go to transplant. It might be an alternative option in patients that are high risk or may not be good candidates for transplants. So based on these patients, we published in JCI not only the case reports of these patients, but then also did kind of a deeper digging of the publications that have been out about the hematological manifestations of DADA2. In our review of the literature, we found that 43% of patients had noted some hematological dysfunction in their phenotype. The earlier kind of descriptions of the disorder really didn't comment a great deal on hematologic manifestations. They were focusing more on the vasculitic components and neurological components. So we feel like this number is probably actually higher. I saw, one of the presenters had commented about 50%, but it definitely does seem there is a significant hematologic component of it as well. Mostly we were finding pure red cell aplasia and then lymphopenia. But then we also feel like our patients do kind of broaden the phenotypic presentation to include bone marrow failure as well. Right. Thank you so much.